The purpose of this podcast is simple. We want you to get to know your doctor before meeting them in person, because you're making a life-changing decision and time is scarce. The more you can learn about who your doctor is before you meet them, the better that first meeting will be. There's no substitute for an in-person appointment, but we hope this comes close. I'm your host, Eva Shea, and you're listening to Meet the Doctor. Welcome to Meet the Doctor. My guest today is Dr. Gary Horndeski. He's a plastic surgeon in Sugar Land, Texas, a place that I love very much. Welcome to the show, Dr. Horndeski. Nice to meet you.
Well, thank you for inviting me.
Can you just give us a little bit of information about yourself first? Seems like a good place to start.
Yeah, I'm a plastic surgeon. I practice in Sugar Land, Texas. I've been in Texas since 1986, so it's been a long time I've been here, practicing plastic surgery. My plastic surgery training was at UT Houston, and then a fellowship at MD Anderson in microvascular reconstructive surgery. So now I'm practicing here since then, and I mostly do breast surgery, particularly breast lifts and breast reductions. And the technique I use is a no+vertical+scar technique, and I've developed that, and I've trained other doctors in the technique, and I've spoken about it many times. I actually gave a lecture about 2 weeks ago in Miami at the aesthetic meeting. I'm scheduled to present in about 2 months in Athens, Greece at the international meeting about my technique. The value of my technique is it's no vertical scars, the way the breast is transferred to the muscle, and this helps people relieve neck, shoulder, back pain without excessive breast reduction. So that's kind of what I'm focused on now in my career.
So I assume patients find you because of this technique. Is that something they come to you specifically for?
Yes, we've done people from like 6 continents, even Antarctica, China, Australia, the Congo, Nigeria, Mexico, Canada, 49 of the 50 states. I haven't had anybody from Alaska yet, but other than that, all the states, and France, England, Israel, Constantinople, and the Middle East, Saudi Arabia, Qatar. So I've been busy with people throughout the world. They find me online, which is what's really good, because it's impossible to advertise all these locations, but people go online and look for something new. And international patients have always looked to America for innovation. And that's what America is great for, innovation, and that's why they come. That's what we're trying to do, promote the concept of innovation with breast surgery. The traditional techniques of breast surgery have been developed in the 1950s, and that's been kind of the standard. But I stopped doing those techniques about 25 years ago and developed my own technique of no vertical scar. So it's fun for me. It's fun to see people from all over the world.
Many of these innovations in plastic surgery happen because you're trying to solve a specific problem, and sometimes they're even a happy accident. Is there a story behind what led you to try doing this a different way?
Sure. I trained at UT Houston, and then I trained at MD Anderson. And then when I got done with my training, the traditional technique of breast lifting, particularly on darker skinned women, leaves a vertical scar. And that vertical scar is just plain ugly. I mean, no woman wants a vertical scar down the middle of their breast. Why would anybody want that if it could be eliminated? So that's the cosmetic reason. There's no vertical scar. Also, this technique shapes the breast more like an implant. Okay, so there's cosmetic reasons. Then functional. I use what's called myointegration. The breast and muscle become one unit. So I tell women, if you take your hands and hold up your breast, that's how you'll feel the rest of your life. It cures neck, shoulder, back pain in many people, or relieves it, or diminishes it. And the third thing that's really good is psychological. The people appear taller, thinner, can go braless, buy different clothing they never wear before. So it's very liberating for the patients to have this procedure done. They're very happy with it and very appreciative. And like I say, they come from all over because they want that alternative available to them.
I think you said Antarctica. How did that happen?
It's interesting. She was a person working in Antarctica. And in Antarctica, you have a lot of time on your hands, I guess. You can't go outside and play, I guess. So they're on the internet all the time. So she found me in Antarctica, then came to Houston to have it done. And so she found me from Antarctica. So that's kind of unusual. That's only one from Antarctica.
I'm pretty sure you're the only person who's ever told me they got a patient from Antarctica.
Yeah, I've never heard one either, but that's kind of cool. Kind of fun.
And so you teach this technique all over the country and all over the world now?
I've taught several people, one in Canada, one in Dominican Republic. I'm working with a guy in Morocco. I've taught several people in the States, yes.
Is it something that you think is catching on? that more people want to learn?
People are very reluctant to change, and particularly in America. I think there's more appeal internationally than in the U.S. because there's so much potential problems with new techniques in America. Litigation is the big fear, of course. There's a thing called standard of care, and people talk about standard of care. Well, if something is new, then it's certainly not standard of care because it's new. So it kind of works against you in some ways, but people are accepting it. I've been doing it so long. Other people are doing things like it. So I think it's become established. And I presented a paper on it. It was published in PRS Global Open. I've spoken on about 5 occasions, 2 international. So it's becoming established. But it takes a long time for something to be discovered to be incorporated in mainstream medicine. It takes years. It's not a quick change.
How many times now would you say you've done this particular procedure in your career?
Close to 1,000. Probably
1,000.
close to 1,000.
Yeah. Now, I often say, this is going to come out of left field, but I often say if I could go back in time to anywhere in the world, I would go back to Houston in the 1980s during the oil boom, like the urban cowboy days, because I imagine that Houston was a pretty cool place during that time, and you were there. And that also during this time, there are some of the greats of plastic surgery were around town. And so did you train with some of those folks?
Yeah, there's of course there was Frank Giroux and
Thomas
Cronin, Frank Giroux, and Thomas Biggs. I did train with both of them. The gentleman who was at St. Joe's downtown, and then the other gentleman was an instructor at Baylor College of Medicine. So I heard him speak many times. Frank Giroux spoke many times. They both died around 94, I believe. They were both died close to the same time. They're both, pillars of the plastic surgery history.
Mm-hmm. Sure. And then you also went through the period of time where implants were taken off the market.
Yeah. Well, I tell you, the problem with implants is they're not lifetime devices. And what you're doing, you're making a hole in the patient. I mean, there's no space there. You're making a hole and shoving something in there. And seeing the people, bigger is better in many thoughts. And the bigger the hole, the more the weight and the more problems it presents. It goes on to have problems because you're putting in dead weight. And like a 450 cc implant weighs a pound. Now, a pound doesn't sound like much, but after 10 or 20 years, that pound has stretched the skin envelope. And the only thing holding up a breast implant is the skin envelope. So that's what's important about what I'm doing. I see a lot of women who present to plastic surgeons who really needed a breast lift. They see a plastic surgeon. Plastic surgeons don't do very good breast lifts, but they do better implants. So, to redirect them towards an implant rather than breast lift. Then they'll come back several years later with a large droopy breast as opposed to just a droopy breast. So it makes it even more difficult. Plus, he's also injured the blood supply. And that's an issue too. So, or even the nerves. So a lot of times I'm hoping that with my technique, the bellesoma method I use for a no+vertical scar technique becomes more available. More patients will avoid the implant and go right to the breast lift to get the result they want. The whole point of what I'm doing, women want an attractive breast. A vertically scarred breast is not attractive. That's why they're shifting to implants. And as we all know, implants have a series of complications. They are not lifetime devices.
So do you still use them sometimes?
Very rarely, like once or twice a year. I use them for exchanges. Sometimes a patient just wants it back. In a woman who has very little breast tissue, very little fat, there's really no alternative other than being flat. So small implants of the order of 200 or 300 cc's. I don't use big implants because they won't last. So I'll probably do 1 or 2 sets of implants per year. I don't do a huge number. I do like over 100 lifts or reductions, but I only do 1 or 2 implants because I know they won't last. And I try to redirect people away from them.
I'm starting to see a clear picture of the patient who would probably love to know what you're doing. And it's somebody who really needs better looking breasts. Maybe they've fallen. Maybe they breastfed some kids and got destroyed by them, or lost weight or something like that, and may still have enough volume, but still doesn't want to have implants. And I think the number of people who don't want implants is growing now.
Yes.
And then may also be combined or independent of the person who doesn't want ugly scars either. They just kind of want to go back to what they used to look like without putting anything in.
Right. Patients just want to be back the way they were, the mommy makeover. They're not asking for anything other than what they used to be. Now, sometimes people will try to do more than that by putting big implants or something like that, but that doesn't really work. So, my goal is to get them back to age 18 again, look like when they were 18. Their breasts were high and round and a chest wall. Breasts move down from gravity, and people don't like that. It just doesn't look good. And the breastfeeding, like I said, and weight changes. Weight loss surgery will cause breasts to hang too. So there's a big demand for breast lifts and reductions. Actually, if you look at the numbers, lifts and reductions probably right now will be exceeding implants in terms of demand because there's so many more people need that. And the problems with implants are becoming well known. It's just getting out more and more.
The other thing I think is important here is that these may be women who don't want to buy themselves a second surgery if they get breast implants and are looking for a way to only do this one time.
Right. The key to what I'm doing is kind of one and done.
Yeah.
What's nice about this is you do it once and you're done. Now, oftentimes I'll do a little revision. I'll touch it up a little scar, but I do that in the local. It's not a big deal. It's like going to the dentist for a filling or something. It's comparable to that local anesthesia, and you drive yourself there, drive yourself home, type thing. So we'll do some touch-ups, but the whole idea is implants are not a lifetime device. This procedure should be a lifetime device. It pretty much lasts a lifetime. I have never had to redo one for mechanical failure, despite doing this for about 20 years, because what I do, I use the excess skin of the breast. Instead of throwing it away, I use that skin to make a cup. And on the base of the cup are straps. And bra straps go over your shoulder, around your back, but with my technique, the bra straps go directly into the muscle below, looping out the muscle. So the muscle and breast become one unit. And with them functioning as one unit, it's permanent. I recently presented my work in Miami, and I have a 5-year follow-up of a woman who had an MRI scan with contrast showing the straps are alive. Unfortunately, she underwent mastectomy because she was BRCA positive and her sister had breast cancer. But so I did my great operation and then take it apart for me. They had to do mastectomy, but for good reasons. And the pathology showed good news for her, no cancer, of course, but also showed that my straps were intact and revascularized and functional. So the whole idea is I have radiographic proof as well as histological proof that the straps and the operation lasts. And that's, that if it lasts 5 years, it lasts a lifetime. It's not going to change after 5 years.
Right.
Living is living. So that's the real good thing about this procedure. You just one and done. That's our goal.
So can you describe where the incisions are in this procedure?
Yeah. The typical breast lift incision is what's called an anchor incision, which goes around the areola, vertical, and then horizontally. Now, my incision only goes, it's an almond-shaped pattern. The almond pattern, the tip of the almond is near the sternum, and the wide part of the almond is lateral because, see, breasts fall down and out. So the nice thing about this almond pattern, it takes advantage of the down and out tissue by getting all that skin and making a cone out. So you take all that skin and just form it into a cone. And then from the base of that cone, you elevate the straps. So it's all one piece, and just loop it in and out of the pec major muscle back to the base of the cone. So that's what's really unique about it. It's really specific for the pathology, but the breasts fall down and out, and that's what the almond's all about.
Many times when we hear about an innovation in plastic surgery, it's followed by a statement like, and when I presented this, everybody yelled at me, or people got really angry, or they told me I was crazy. Does that ever happen to you?
All the time. Yeah, absolutely. Yeah. It's an ongoing battle. Whenever something new comes up, the first thing is that can't work, and then after a while say, well, that might work, and then say, well, I guess it can work, but then people say, well, everybody knows that. So it goes through a phase of denial to acceptance. So you go through that phase, and when I first presented this, I was attacked viciously. My website was torn apart and everything. I had all sorts of things happen. People attacked my website. And of course, they attacked me too, but that's given it. But as time's gone on, through various things like Real Self, I've got the word out there, and people have come to accept what we're doing.
Yeah, I was just wondering where you got these drawings of me for your website. No, I will link in the show notes for anybody who's listening the illustrations, and I think they're really helpful to visualize how this is different in what you're doing. And I'm sure that you probably tell people to go to this page 50 times a day because it's really useful to actually see it in action. Were those drawings something that you developed yourself?
Yeah, we developed these drawings and we have some computer animation. We have a variety of things available for people to understand and to distinguish ourselves from the traditional techniques. That's the whole idea. We want to give people an alternative. Many women are sitting on the sidelines. They'll do nothing before they do the vertical scar technique. So they're looking for something. And when they finally find me, then they say, "Oh my gosh, this is what I've been looking for 10 years." I've had people actually following me for 10 years because they couldn't believe it's real. And I remember I had a doctor. I think she was out of New York, who was contacting me 8 years ago. She contacted me again. I said, "Well, listen, if you're still not sure, call me 8 years from now. It's like going to be 10 years now." So it's like, yeah, I mean, I'm around, and if she's still around, and I'm still around 8 years from now, then we can do it. But people, a lot of disbelief, and which is understandable because a lot of times people say, "Well, if that technique really worked, everybody would be doing it that way." Well, everybody can't do it that way because they don't understand how I'm doing it. My background is in math and physics and engineering. So what I do is I scan the breast, I determine the critical surface dimensions. From that, I derive a mathematical solution for each breast to make a hemisphere. And then that generates a blueprint. And from that blueprint, then I can do the surgery. No blueprint, no surgery. So that's how it works. You got a computer solution. So it's all math-based.
And did you develop software to do that yourself too?
Yeah. Well, we have a software company, but I give the input to the software company. I don't write code, but I write the algorithms. The algorithm that allows you to do it.
Right, the math behind the code.
Right.
That makes sense. Yeah, I mean, the cases are beautiful, and I'll make sure that we put a link to these that is easily found in the description of this podcast so that if anyone wants to look at what you're doing, those pictures will be there. This is very exciting.
Yeah, it's really the whole idea now is instead of word of mouth, it's the world of mouth. The whole world can see things now, and you don't have to just ask your neighbor, who do you go to? You go on, people find me, they go online, they look at breast lift or minimal scar or whatever, and they are able to find me sometimes quickly, sometimes longer time to find me. But it's a different world, and it also allows you to communicate without high cost. You don't have to, I can't advertise in London. I mean, how am I going to, you can't advertise the world. I mean, the cost is prohibitive. But the internet is basically free. I mean,
platforms like Real Self are great for getting information out that's different.
Yes, that's the whole idea. Give people an opportunity to find something that they can really use for their life, and also give them a chance to interact. The good thing about Real Self, they can contact patients and say, "Hey, you had it done. What do you think?" Really, that kind of thing. It's kind of back and forth. It's not just it's just me saying I'm great or something like that. I want to hear from the patients, and when patients make negative comments, that's also helpful too, in the sense that if everybody says something positive, that's good, but you kind of learn from mistakes or from people who say, when I first started doing this, I used to use 3 points of attachment. Then one patient said, "Well, the breast is kind of triangular because there's only 3 points. So now I have 9 points of attachment with my straps." So the feedback from patients helps advance the technology. And that's what you want. You learn from your mistakes more than your successes. And that's kind of a general rule of surgery across the board.
One of my favorite questions to ask is always, what have you learned from listening to your patients? And you just answered it as one of the things, and I'm sure there's many more, but sometimes people look at me like, what could I have possibly learned from them?
Right. Oh, yeah. Yeah. Sometimes it depends on the patient. Sometimes that's true.
Sometimes, yes.
What I like about what I'm doing is that it selects for more intelligent patients. They've done their homework. They've looked online. They come and ask good questions. They want to know how it's done. Not someone who's just like, "Hey, I was walking by your office. I thought I'd stop in." Those people, they're clueless to what I'm doing. They think it's like what everybody else does. But no. The people who do their research, and then they ask good questions. And those are the ones that are most likely to do the procedure because they've been looking and looking and looking and dissatisfied. I mean, when people come from Australia, that's a long flight. That's a long way to go.
Sure. So when people come from out of town, do you and your staff kind of help them figure out where to stay and make sure they're comfortable? Yeah.
Yeah. We have a whole protocol. The hotel arranged with the hotel, they have free shuttle service, things like that. So we're probably 25% of my people are within Houston, another 25% in the state, another 25% out of the state, and probably another 25% out of the country. So it's a variety. Now, those ratios have gone down. Out of the country has gone down markedly since COVID, but it's starting to come back up. I have a lady coming from Portugal, and I have another lady coming from France in the next month or two. But we were shut down for a while with COVID, of course.
Yeah. This must keep your days incredibly interesting, meeting all these people from all over the place.
That's the fun part about it. It's not boring. You see different people, and also training people. Like I said, I'm going to Athens, Greece, in about 2 months or so, and it's nice to talk to the international doctors too, get their perspective on things. It's a totally different world. America, we think we're the greatest in all that, and in many ways we are. But in some ways, it's good to see some input from other countries, and a lot of times they can do stuff that we can't get away with here. There's certain things they do that we just can't do here. They do all sorts of stuff that's very innovative. But for instance, like implants, they can use polyurethane implants in Europe. We cannot use in America. There's a variety of things that they can do there that we can't do there. And a lot of things are done first in Europe and then brought to America because it's easier to get established there. Like if you want to have clinical studies, if you try to do them in America, it's a big cost to do the clinical study. But in Europe, it's less expensive. They do it there, and then you can kind of transfer the results and look at it here. So it's a lot more open there.
Have you ever done any studies through your office?
Oh yeah. Well, my papers have been like the last paper I published was a 7-year review of my patients. I did 77 patients in 2015 for lifts and reduction. I followed them for 7 years, and I got my results. 91% of my people at 7 years can go without a bra, and that's something that people don't even discuss in other techniques. They go braless even at 7 years because the whole technology is so much better. They don't need to wear a bra. It's unbelievable. Again, the other techniques don't even discuss it because it can't be done. It doesn't work for the other technique. But this internal bra that I make is all your own tissue and it's living. See, bras, as you know, a bra is a passive device. It's elastic. It's rubber. It stretches to where you throw away. Bras do not last a lifetime. What I'm making is your own skin, as long as you're living, as skin's living, and the muscle. The muscle provides the elastic recoil. The muscle provides active lift. It's not dependent on stretch. So you have tone. See, within your muscle are what are called neuromuscular spindles that sense length, velocity, acceleration. So when a woman's laying down, the breasts are fine. But when a woman stands, the breasts want to drop. Once those breasts drop, they're pulling on the muscle. And the sensors with the muscle, you're lengthening. So the muscle responds by contraction. So just like when you stand up, you don't fall over. You don't lean this way or that way. You stand straight. But because you have these neuromuscular spindles, it's sensing your position. And the same thing is true with the pec major muscle. Yeah, the muscle we use is the pec major muscle. When you do a pull-up or push-up, it lifts your whole body's weight. So if you're let's say you weigh 200 pounds and you have 2 breasts, okay? Well, if your muscle can lift 100 pounds each side, it can hold up 1 pound breast. I mean, if the muscle has a capability of holding 100 pounds, it can hold 1 pound, right? I mean, that makes sense. So the muscle has so much reserve that it could care less about 1 pound, and that's a decent sized breast. And even if you have a 2 pound breast, still the muscle is capable of a 100-pound lift. So the whole idea is what we're doing, does not depend on the external skin envelope. The external skin envelope wraps around your neck. That's why you have neck pain. It goes over your shoulder. You have shoulder pain. The bra digs in, all that stuff. All that stuff is gone because you're attaching to the muscle directly behind there. And the muscle does not have pain sensory cells like the skin does. There's no skin being compressed. So the muscle itself is providing the active lift. So it's the difference between an airplane and a glider. Airplane, you can fly anywhere you want. You go up and down or whatever. Glider, you only go down. It's all passive. That's the analogy.
What is the recovery like after this procedure?
Same as the other procedure. I have people after 1 month, do anything you want. After 1 month, you don't want to go higher than about 9 degrees because you're stretching your muscle and your muscle hurts. So we give people muscle relaxants after surgery. We give them pain pills, but also muscle relaxants. So that's the distinguishing factor between the two. Probably more muscle pain than the other procedure because we're using the muscle, putting it to work. But other than that, people are back normal and within a month of back. A lot of people I work with, of course, they're not doing manual labor. They have internet jobs. They're at a desk or whatever all day. They go back to work within a week or so. Once they go back home, they go to work. But if you had a demanding job, like some nurses who have to lift patients, I tell them, yeah, you got to be off a month. Can't lift anybody for a month. But most jobs are more sedentary now.
So you're innovating, you're teaching, you're taking care of patients, you're probably writing. You definitely are spending time thinking, and I'm curious what else you like to do, especially away from work.
No, away from work. Okay. I have a lot of hobbies. All right, number one hobby, electronic stuff. I like to restore and rebuild electronic equipment, like audio equipment particularly. So 2 weeks from today, I'll be in Xenia, Ohio, where it has the world's largest ham radio show in the world. So it's every year around this time. It developed there from Dayton, Ohio. Dayton has a big military base there, and a lot of military surplus was there. So this became an area where people go for ham radio stuff. It's two-way radio things. So I go to that show every year if I can. That's one hobby.
Do you have a ham radio at home?
No, I just do audio. My friends might do a ham, but I just do the audio stuff. I like audio amplifiers and tape decks, record players. I like playing with those. And restoring old radios, old tube radios, they're really fun. They're really very primitive and compared to what's available now. See, the stuff available now, when it breaks, you throw it away. But the old stuff you can actually fix. Tube radios glow, and they're kind of magical. They're kind of really neat. It's kind of old school. So that's one hobby. My other hobby is model railroading, trains, toy trains, and I like that. Yeah. So collect toy trains. I've been doing that since I was a kid. In fact,
what size?
HO.
Yeah.
When I was about 10 years old, I got trained. And then when you play with toy trains, you have to learn about electricity. So that's how I get into electronics. So the trains went to electronics, and then so I do that. But that's kind of the fun stuff to do outside the OR. But when you have spare time, which is nice. It's nice to have spare time.
Is there anything you're looking forward to on the horizon, either work or otherwise, a trip or an event? You talked about Greece a little, yeah.
Let me tell you what I'm looking forward to. There's something called Obesity Week. Every year, the first week in November is usually Obesity Week, okay? And I went last year. This is true. It's called Obesity Week. And last year I went to Obesity Week, and I gave copies of a book I wrote. I wrote a book on weight regulation. And I'm trying to promote some contests on weight regulation, just like I did on breast. So the whole idea is you can approach weight regulation mathematically and help people understand how their weight's controlled, help them lose weight. So I wrote a book on it. I published it. And I submitted 3 papers for the meeting. It's going to be in Dallas this year. It's going to be in Dallas in about mid-October. So hopefully I can go there and present on obesity too, because a lot of people who come for breast have weight problems too. And as we know, weight issue, 2/3 of Americans are either overweight or obese now. And that's a real problem healthcare-wise. About 10% of our healthcare cost goes for obesity. And if you could eliminate obesity, that'll change heart disease, cancer, a whole variety of things. So I like to think I'm a scientist first, a doctor second, a plastic surgeon third. So there's other issues here involved, not just breasts.
A lot of people say stuff like that, but you, I think, are actually living it.
Yeah, I'm trying to live it. I like science, technology, and math. It's fun. Yeah.
So what's the elevator pitch version of the book that you wrote about weight regulation?
Yeah, okay. People are looking for the magic pill. Okay, there isn't the magic pill. I mean, it's not. You're not going to cure obesity until you understand how weight is regulated. And you will not understand how weight is regulated until you understand control system theory. And my background in math and physical engineering, I did study control system theory in college my sophomore year. And it comes down to this. It's like, what does the body actually sense? How do you feel satiety? How is satiety generated? Satiety is generated mechanically. Okay, it's a mechanical phenomenon. And within the wall of the stomach are what are called interganglionic laminar endings that sense pressure or tension. And when you eat a meal, you think the meal is going to your stomach, but it's not really not just going to your stomach. When you eat a meal, it's going to your stomach, but your stomach is inside your abdominal cavity. And the cause of obesity is mechanical failure of the abdominal wall. Children are obese because they don't develop their abdominal wall. They don't play baseball. They don't do sit-ups. They can't do anything like that. So they have a loose, weak abdominal wall. Now, this typical story we hear all the time as a doctor. Before I was married, I weighed 120 pounds. And then I had a pregnancy, went to 130 pounds. Another pregnancy, 150 pounds. And a third pregnancy, I'm 200 pounds. And now I can't lose weight. I'm 200 pounds. I used to be 120. What happened, doctor? And you say, well, your hormones changed or this or that. Well, that's not what changed. What happened? Each pregnancy expanded your abdominal cavity and damaged your abdominal wall. And you're not achieving satiety because you have a bigger container now. So when we do the mommy makeover, one of the things I do is I make the container smaller by using mesh to reinforce the container and create satiety. So that's what it comes down to. You have the stomach and fat. See, fat is distributed throughout the body by a fixed ratio. There's a certain percent of fat intra-abdominal. Okay, in women, it's only 20%. In men, it's 25%. Men have more intra-abdominal fat. And what that does is it allows men to sense fat increases quicker or with less changes in volume. So they have more intra-abdominal fat. So the whole key is when you eat a meal, you have intra-abdominal fat is accumulated versus meal size. If you have a lot of fat intra-abdominally, they won't eat a bunch of meal. If you have little fat, they'll eat a bigger meal. And so the whole idea is if we can compress the abdominal cavity and create satiety sooner, helps to reduce weight. And that's what it comes down to. It's all biomechanical. So I've been trying to promote this concept. I wrote this book a few years back. I've been trying to talk to key people about it. But as you know, everybody's going crazy over GLP-1 agonists.
That was my next question.
Yeah, the Ozempic. Okay. What does Ozempic do? Well, it decreases GI motility and it slows the absorption, so the food stays in the abdomen longer. No one has hypothesized Ozempic deficiency causes obesity. It's not going to cure obesity, it's going to help with things. But the whole idea is you must understand the physiology of weight regulation, what fails, and how you correct the actual cause of obesity. So the actual cause of obesity is biomechanical. Everybody keeps saying the same thing. It's diet and exercise. Why diet? Okay, the fat content of food varies widely. Every fruit and vegetable, except for corn, is less than 1% fat. You can eat all the fruit and vegetables you want. You can't gain weight. There's no fat in them. All the fat in your body is fat you ate. You don't make fat. Fat is what you have from your diet, okay? So that's one thing. And people don't realize fat's exponential. Like, all fruit and vegetables are less than 1%. Like, corn's the only vegetable that's higher than 1%, it's 4%. Corn, turkey, chicken's about 4 or 5%. And then cheese and nuts and chocolate, 50% up. So there's 0.5%, 5%, 50%. There's a whole big scale of fat content. It varies widely. And unfortunately, or fortunately, we're programmed to like fat. And that's why we survived. When the famine hit, thousands of years ago, the fat ones survived, and the ones that are skinny ones, they didn't make it. So to be a little bit overweight was bad, was in your best interest. But now, of course, we have a sedentary lifestyle. So we don't have to be physically fit anymore. We sit at a desk, or we have a desk job, or women get pregnancies. Children aren't active anymore. Show me a fat person who's not round. Okay, show me a fat person who can do 100 sit-ups. No, fat people can't do sit-ups. Fat people are round. You become round. And it's not the roundness causes obesity. It's the fact that your abdominal wall became weak and you fill the cavity. You're filling the container. So you tell people, well, wear abdominal binder. Well, that can help to a certain degree, but the trouble is the abdominal binder, a lot of the pressure gel by binder is dissipated by the fat because you got this much thick fat before it gets to the abdominal cavity. So what can help people? Liposuction. Now, liposuction is actually a treatment that can be used for obesity. And it's frowned upon because you can only take off 10 pounds at a time. But if you take 10 pounds off the abdomen, give them in a binder, and 10 pounds and 10 pounds, you repeat it and get them down to the weight and then do a tummy tuck on them. So there's other techniques other than just the intestinal bypass and the sleeve. And again, those techniques have problems too, like the intestinal bypass, malnutrition problems with that, and it's irreversible. Gastric sleeve, irreversible. You have problems with those things too. So the whole idea is if we can understand the physiology of weight regulation, then we can cure obesity. But until we understand regulation, so you just go on Amazon or Google rather. Just Google how weight control. They give you this complex runaround story that all these hormones are interacting.
It can't be that complicated.
It can't be that complicated. No, it can't be. Right. No. Here's the key thing. It's like this is one thing that really makes sense at all. Okay. When you eat a meal, you achieve satiety within about 5 or 10 minutes. I mean, you can gobble down a meal in 5 or 10 minutes and feel full. Once you reach satiety, you've not absorbed the meal. The meal's still in your stomach. You don't know what you ate. You could have eaten sand for all your stomach knows. This doesn't know how much protein's in there, how much carbohydrates. You don't know what you've eaten.
Once you're not hungry anymore, you don't even remember what you ate. And I've told myself this for years.
Right.
I could eat a giant salad or a pizza. Once I'm full, it's irrelevant.
Right. Satiety is achieved biomechanically, not biochemically. And so the whole idea is if you can understand that it's a mechanical situation. And it's very simple. You have a container, you have accumulated fat on one side and the stomach on the other. And what really proves this whole thing, the rat study was done on this. In 1985, a guy named Koopman up in Calgary did an experiment called about one-way intestinal cross intestines. Anyway, I talked to the man, and he did all the analysis on these rats and everything, and we came down to the conclusion there's an inverse relationship between meal volume and fat weight. And they proved it in the rats. So the rats that had more fat ate smaller meals. And the rats that had smaller volume ate bigger meals. And see what he did, he took rats and he sewed the two rats together. Now, this is kind of not kosher anymore. I don't think you can do things like that anymore. But what he did was by sewing the two rats together, he exchanged the circulation. So any blood factor controlling eating was between the two of them was identical. The blood, So the only thing that was separate was the neurological system, and he crossed the intestine. So one rat would get the food before the other rat would get it by bypassing the intestine. It was a brilliant study, brilliant guy. I talked to him twice, and he came to the conclusion it's either a stomach or a small bowel. He spent a whole career looking for a small bowel. I talked to him about a month or two before he died. And he said, "Is it a small bowel?" I said, "Yeah, I know, it's stomach." So what it is the interganglion lemon endings within the wall of the stomach that sense pressure generated by the combination of food and accumulated fat. And it's that simple. And I wrote a whole book on it. Again, it's a mathematical book, and people don't like math in general, so it's hard to understand. So, but what I'm doing now is writing a lay people's book. Right in front of my desk right now, I'm working on that.
If you had little kids right now and you wanted them to grow up and not ever become overweight, what would you do with them?
Tell them to do 100 sit-ups a day.
Sit-ups.
Sit-ups. A core exercise. Sit-ups, planks, Pilates. You've got to do cores. Burning calories won't do it. Because if you burn calories, you'll absorb the fat, but then when you go to eat a meal, there's less intra-abdominal fat, and you eat more to compensate. So you're going to keep that thing balanced. So burning calories is essential to lose weight. You must lose 3,500 calories to lose 1 pound. 1 pound of fat equals 3,500 calories. It's about a day's supply of food. So if I had children today, my kids are all grown up, by the way, but and they're both thin, and they're both very active. And they're like BMIs like 22. But the whole idea is be physically active, have core strength, and that's what I would emphasize the most for. And I also tell them not to play football either. I won't play football. I want hitting their heads. Football. No football for them. Other sports.
No, I have girls, but one of them did just ask me, "Mom, can girls play football?" I said, "Well, technically."
Yeah. You don't want to hit your head, though.
You can do whatever you want to, honey.
Yeah.
I hope it's not football.
Yeah, right. Do something else. Run track.
Mm-hmm. Lacrosse.
Yeah.
I am so just captured by everything that you've told me today, and I love what I do because I never know what to expect, and I'm always surprised. And I'm so grateful that you took the time to tell us all of your incredible stories and the work that you're doing. And I hope that we can come back and talk to you again about some of these things. Like maybe we'll do an Obesity Week special.
Yeah. If you do that, that'd be great. I'd love to talk about obesity because it's like you got to get the ideas out there. You've got all these charlatans trying to capitalize on things. Special diets and all that. It's not that way at all. It's simply biomechanical. You show me a fat person who do 100 sit-ups. They don't exist.
I feel like I was always on the right track because the volumetrics is the one that made the most sense to me. And so my husband would always say this dumb thing, and he'd be like eating breakfast, and he'd say, "No, I need more calories than that." And I'd be like, "No, you don't. You just need to feel full."
Right, yeah.
Like the trick is to feel as full as you can with the least amount of calories.
Right, yeah. And again, fat content. You can fill up with fruit and vegetables. You eat yourself sick. You explode. You can't get enough fat in it. And fat is 9 calories per gram. Okay, the fat density of food varies widely. Okay? Fat is the highest calories per unit volume. It's really, really, you pack it in there. So eat low fat density foods, and you'll get satiety. Now, like fiber is good for you. All the high fiber foods are fruits or vegetables except for nuts. Nuts have high fiber, but you don't want nuts. Nuts are about 50% fat. Nuts are kind of, they're good and bad. Nuts are good and bad, but all the fruit and vegetables except for corn. Now, corn feed cattle, make them fat. See, corn's got almost 5% fat, but every other fruit and vegetable about 0.5% fat.
This is why riced cauliflower is the best thing ever invented.
Have you ever had it?
Riced cauliflower? Oh, you can fool yourself into thinking riced cauliflower, you can replace spaghetti with it. You can use it instead of rice. And it has like no calories at all. So my lunch every day is a bag of riced cauliflower with ground turkey. And
that's low fat. That's very low fat.
Yeah.
But the thing you're going to have to do, I tell people, low fat diet, core exercises, abdominal binder. You can go so far with that. Okay. If you want something surgical, liposuction, you can do liposuction on anybody. Take off 10 pounds. Do it on your abdomen, and then wear a compressive garment, and that will help you compact your abdominal wall. And eventually, keep doing that, and you can lose the weight. So it can be done. It's less invasive and less dangerous than the bypasses and
for sure.
Sleeves, much less because you're extra abdominal. You don't have to go to the abdominal cavity. And the pathology is your abdominal wall. The problem is your abdominal wall. There's 2 parts of the abdominal wall. One is muscle, which you can build up in time. Unfortunately, women who have pregnancy, they've torn their fascia. The fascia is the strength layer. Now, a hernia is a complete tear in fascia. Obesity is a partial tear in fascia. That's the only difference between a hernia and obesity. If you look at, and in my book I show a picture of it, but the fascia should be like a nice white sheet. It's all spread out like this. It's all torn and stretched out. But when you have a 100% tear, that's a hernia. And the treatment for a hernia is not going to the gym. You have a hernia, you need surgery. And the treatment for obesity, you've got to rebuild the strength of down the wall. And you cannot repair fascia directly unless you do suture. I mean, you can't heal your fascia. It's been stretched out from pregnancy. It's a done deal. It's like a spring. You take a spring, overstretch it, never goes back. It's still a spring, but it's stretched
really,
out.
There's no muscle that can be torn and repaired any other way than surgery, right?
Well, the muscle just stretches. See, what happens with muscle, as the muscle stretches, it loses mechanical strength. It loses mechanical strength, it stretches more. It's a positive, it's a runaway train. It just keeps worse. The whole idea, you've got to get control of it. That's where the abdominal binder and core exercises come in. Get an abdominal binder, good core exercises, low-fat diet, planks, Pilates. And that's what I tell people to do to help them lose weight. I don't believe in green tea or any other magic potions, It just doesn't work, But every study has said the same thing. Your diet and exercise, diet and exercise, diet. There'll be people who will do some of these surgical procedures, but you still eat through that. You still overeat it. You can outstretch that stomach. You drink milkshakes. That's what people have proved they can undo it. So it requires the cooperation of the patient and understanding of what you want to change. And it's all abdominal wall. So, like I said, my background is math, physics, and engineering, and you can apply that to obesity. You can apply it to breast surgery. That's the whole idea. A lot of things you apply science to it, where the way you solve a complex problem as a scientist, you make a model, a simple model. You write the equations for the model, solve the equations, solve the model, solve the problem. So that's what I do with breast surgery and with obesity. It's all a series of equations that determine it, and I figured all that out. And try to promote that. So like I said, I submitted 3 articles for the Obesity Week, and let's see if they publish. They'll let me present. And I talked to some of the bigwigs there. I talked to a lot of the big shots there at the meeting. I gave them copies of my book. I didn't hear one word back from any of them. I gave like 5 copies to all these big shots guys. One guy's from Mass General, and other guys from the Institute of Louisiana, another guy's from Colorado. All these big shot guys, and they didn't even send me a thank you card. I guess I shouldn't expect that. I guess
there's still time.
Yeah, we'll see. Well, like I say, I'm looking forward. I'll find out in June whether I'm going to present or not. But submitted 3 papers, and we'll see if they'll allow me to present. But if I'm in the audience, I'm going to ask them some tough questions.
I expect you to. If you had a podcast, you could just tell everyone everything all the time.
Yeah. Well, I'm not a tech guy in that regard. I'm just a plastic surgeon, and I like that. I'm good at what I do. I'm not that technically oriented. You're more technically oriented with that, so I'll let you.
I just do it every day.
Yeah, you do it every day. I do surgery every day, so you guys can run with that.
Before we wrap it up, I'm curious, when did you know that you were going to be a doctor? Was there a moment or an event?
Yeah, kind of it's called the Vietnam War. Okay.
Oh.
The war was going on, and one of my friends was a pre-med student, and he said, well, medicine's deferred, and I said, I understand that, and I see I was interested in biomedical engineering. And they had a lottery back then. I don't know if you're familiar with that. There used to be a lottery for the draft. And I was, I think, number 13. And that year they went to 330. Like 90% of people in my class were drafted. And I used to get a call from a recruiter every day, like every weekend. He wanted me to join up, wanted me first lieutenant. Well, at the time, the first lieutenants were all killed by their own men because they were incompetent. So no, I didn't want to go into the military. And these are alternatives for me. So I applied to medical school and I got in. I was fortunate. And I thought I was going to be a pediatrician. I liked psychiatry a lot. I thought I'd be a pediatrician. I did not like the sight of blood. I don't know why. Here I am. Figured that out. I still haven't figured it out. I think what I don't like is the sight of my blood. I think that's what it is. I don't like my blood, but other people's blood doesn't bother me, I guess. But how I became a surgeon, I don't know. It's just because I like mechanical stuff too. I like the cut and sew and stuff. So it's a fun job being a plastic surgeon. It's really nice.
Mm-hmm. If someone's listening today and they want to find out more about you or reach out, where would you suggest that they go to learn more about?
Probably my website, just my www.horndeski.com, where I'm listed. Yeah.
I'll make sure we link that in the show notes.
Yeah.
Thank you again for for being on the show today. We really appreciate it.
Well, I hope it was entertaining to some degree as well.
Definitely. Yes.
Different type of approach. Well, it's nice. Not all doctors are the same, but a whole variety of people, which is good. And I like to think I'm different than most of them, and have a different approach to it. I have a different background, which is good. And that's what we need, a variety of people.
That's how we get better. If you're considering making an appointment or are on your way to meet this doctor, be sure to let them know you heard them on the Meet the Doctor podcast. Check the show notes for links, including the doctor's website and Instagram, to learn more. Are you a doctor or do you know a doctor who'd like to be on the Meet the Doctor podcast? Book your free recording session at meetthedoctorpodcast.com. Meet the Doctor is made with love in Austin, Texas, and is a production of The Axis, TheAxis.io.